Thank you, sir. Greetings from Bangladesh to the all foreign faculties of AIOS conference. Respected chairpersons, co-chairperson, convener, honorable panelists, and moderator and learned audience of virtual conference. Very good evening to everybody. I am Dr. Shaymal Kumar Sarkar. Welcome everybody to my presentation. Atypical optic neuritis. What next? Optic neuritis is an inflammation of the optic nerve, mostly affect the young adult of and the middle-aged female. It is about 31% of the total optic neuropathy of this age group. Usually, this optic neuritis is present with central blurring of the vision with or without pain, color vision defect, REPD, central or centrocecal scotoma, normal optic nerve head, or hyperemic disc swelling, and MRI, engorgement and enhancement of the optic nerve. This is the well-known classification of the optic neuritis, ophthalmoscopic and etiological classification. Another classification, it is a clinical classification most widely used nowadays. And another entries of the optic neuritis, that is typical versus atypical. Before going to my topic, I want to highlight some points of typical optic neuritis. This is the patient present with sudden painful visual loss in right eye with right eye hyperemic disc swelling, and on MRI there is no demyelinating lesion in the brain MRI and optic nerve enhancement and engorgement. Without treatment, after 30 days, best corrected visual acuity in right eye 6-9. Patient under follow-up and observation. This optic neuritis is most likely idiopathic cause or due to para-infectious cause because history of flu-like illness 2 weeks back. Another patients having severe visual loss, painful visual loss in the left eye, but optic nerve head is normal. But in MRI, there are demyelinating lesion in the brain parenchyma. In the CSF study, the oligogonal band of IgG is positive. So this optic neuritis is due to multiple sclerosis. Patient treated with IV methylprednisolone and immunomodulator, and after 3 months follow-up, visual acuity nearly normal, that is 6-9 in left eye. These two cases are the example of the typical optic neuritis, where subacute or acute onset of painful unilateral visual loss, normal to mild hyperemic disc edema without hemorrhage and exudate, usually have good visual recovery with or without treatment. Now, atypical optic neuritis. A male patient present with severe bilateral painless visual loss in both eye and bilateral disc swelling is there, and the MRI, there are no demyelinating lesion in the brain parenchyma and spinal cord. On the serological test, anti-NMO or anti-AIOC2021 antibody is positive. After treatment and 3-month follow-up, the vision in the left eye is 6/24 and partial optic atrophy in the left eye. So this patient, this bilateral optic neuritis to anti-AIOC2021 positive NMOSD disorder. And another patient, sudden visual loss, painful visual loss in the right eye with mild disc swelling in right eye, and in MRI there are demyelinating lesion in the brain parenchyma. This is not like the demyelinating lesion of multiple sclerosis. Patient having same history, same attack in the left eye 2 months back with weakness of the limbs and mixed problem. And serological test, anti-myelin oligodendrocyte antibody is positive. Patient treated with IV methylprednisolone and immunosuppressing agent, and after 3-month follow-up, visual acuity 6-9 in both eye with normal optic nerve head. So this bilateral sequential optic neuritis most likely due to NMO positive NMOSD disorder. Another patient present with painful visual loss in the right eye with disc swelling, and another eye mild pallor of the disc. MRI is normal, no demyelinating lesion. Patient having same history, same attack, repeated attack in the left eye when stop the treatment by steroid. The relevant investigations like anti-MOG antibody, anti-NMO antibody, even MRI scanning of spine is normal. With treatment of the steroid, patient is well. And after 3-month follow-up, visual acuity in right eye 6-9 and left eye 6/18. So this steroid-dependent optic neuritis, bilateral sequential optic neuritis, most likely due to chronic recurrent inflammatory optic neuritis. And another patient severe visual loss in the left eye, but optic disc is normal. No dematic lesion is there. Patient is the known case of the SLE. ANA and anti-CCP antibody positive, anti-double-strand DNA antibody also positive. And after 12 weeks, best corrected visual acuity is PL, no improvement of the vision with treatment. So this and pale disc in the left eye. So this RVN is due to systemic autoimmune disease, SLE. And another patient, the painful visual loss in right eye for 5 days, and no sense in the no demagnetization in the brain MRI, but only mild enhancement of the optic nerve sheath. Here, all investigations are negative, but anti-nuclear antibody is positive. Treated with systemic steroid, and after 3-month follow-up, visual acuity in the right eye in 6/18 with mild pallor of the disc, and this patient is diagnosed as autoimmune optic neuritis. So, out of 5 patients, 4 patients having mild to moderate degree of optic neuropathy in follow-up visit after treatment in these atypical cases. So atypical optic neuritis are the heterogeneous group of disorder presenting features suggestive of the inflammation of the optic nerve, present with unilateral, bilateral, or sequential painful or painless severe visual loss. Normal disc to severe optic disc edema with or without hemorrhage and exudates. Continued worsening vision over weeks or months. Poor visual outcome if not diagnosed and treated timely. The examples I already discussed in my scenario. Now the mimickers: ischemic optic neuropathy, acute toxic optic neuropathy, compressive optic neuropathy, lever-headed optic neuropathy, all are the mimickers of the atypical optic neuritis. It must be excluded by the appropriate history, examination, and investigation. Now workup. For diagnosis of the atypical optic neuritis, need demographic profile, detailed clinical history, neuroocular workup, and complete neurological assessment. And investigation. This is the mainstay of tools for diagnosis of the atypical optic neuritis. It is not only important for establish the diagnosis, but also exclude the other differential diagnosis and mimickers. Now treatment: IV lethal prednisone 5 to 7 days, followed by oral steroid and immunosuppressive therapy longer period. In acute phase of disease, needed plasmapheresis and IV hemoglobin, and essentially refer to neurologist, rheumatologist, and internist for multidisciplinary treatment. Challenges: lack of awareness of the patient, lack of investigation facilities. In the all corner of the Bangladesh, the investigation facilities are not available in the big city. Financial constraints, maximum of the tests are costly, and lack of multidisciplinary practice in the challenges of diagnosis of the atypical optic neuritis. Now, my message: atypical optic neuritis can have devastating visual outcome. To improve or stabilize the vision, it is crucial to make the correct diagnosis and appropriate treatment in conjunction with neuro-ophthalmologist, neurologist, and rheumatologist. I am grateful to my patients, my institute, National Institute of Ophthalmology, OSB, and AIOS for giving me the chance, and my teachers, Professor Abha Madam, Professor Muqtadish sir, Professor Sharfuddin sir, and others, honorable panelists, my team members, Arvind Eye Care System, and Green Eye Hospital. Thank you. Thank you, everybody.